Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome back. Look who we have here today, Autumn Henning. Woohoo! Autumn, I'm so delighted to have you on. I've been thinking about you for a long time, and I'm like, I have to get Autumn on. Your name comes up all the time. I see you have courses. You're revamping your course, which we're going to talk about. You're a speech pathologist, so we're one of the same, and you have many specialty areas. So I'm going to talk all about your background and everything, and we're going to go over a lot of questions, a lot of TOTs, tethered oral tissue questions today. And you are a speech pathologist, certified orofacial myologist, international board certified lactation consultant. You're an educator, and you're the founder of Chrysalis Orofacial. So thank you for all you do, and thank you for being here today, Autumn.
Oh, thank you for inviting me. And I know all of your podcasts are going to have a great impact on people out there looking for answers. So that's what it's all about.
And that's why we're all here, is looking for these answers and these issues that our patients face, we face, family members face, are so multifactorial that there's never just one thing. And that's why, right, I'm interviewing all these different specialists to put these pieces together. So I'm going to go over your bio, and then we'll just dive right into some really good discussion points.
Sounds
so
great.
Autumn Henning is, like I just said, SLP, so speech pathologist, certified orofacial myologist, IBCLC, which is a really cool addition to your foundational training. I want to talk about that a bunch today. You have your practice in Greenville, South Carolina, and it's called Chrysalis Orofacial. And Autumn specializes in evaluating and treating tethered oral tissues, infant feeding, swallowing, and orofacial myofunctional disorders across the lifespan. She also serves as a voluntary assistant professor in the Department of Communication Sciences and Disorders at the University of Kentucky College of Health Sciences, and was a founding member of the International Consortium of Oral Ankylophrenia Professionals, so ICAP, which is so funny because the last 3 interviews I've done, people are on the board for the ICAP. So this name keeps coming up, which is wonderful. Autumn is internationally recognized for her evidence-informed, interdisciplinary approach to tethered oral tissues. Through her highly regarded continuing education programs, including TOTs, Tethered Oral Tissue Specialty Training, Plot the TOT, the Stones Approach, and the E3 Model of Care, she has educated thousands of healthcare professionals worldwide. Her work emphasizes functional assessment, critical clinical reasoning, interdisciplinary collaboration, and helping patients achieve optimal outcomes from infancy through adulthood. Autumn, thank you for being here.
Thank you. That was a mouthful, but here we are.
That was a mouthful. And I got it all out. And what I really am going to love to talk about also is the infant population and your IBCLC specialty certification. So this is kind of fun because I've been a speech pathologist for a while, like you, and I don't work with the infant population. I think it's really important for people to know and understand that that is a specialty area.
Yes.
This requires intense specialized training in the early intervention population. So not just infants, but in that birth through the 3-year-old age range. It's a different skill set. When we're talking about oral function, it's a different skill set. And I feel like I don't work with that age range in terms of feeding and oral sensory motor because I don't have enough training to do that. So I really want to talk about what that entails. But before we get into that, I want to know, how did you get started? What inspired you to become a speech pathologist, then to specialize in tethered oral tissues, and then get your breastfeeding certification? Because that's a lot, and a lot of amazing things you have.
Yes. Oh gosh, that's a long story. Essentially, I come from a background of both medical, dental, and then educators. So speech pathology is kind of the marriage of those two, education and the medical side. So I did some job shadowing in high school, and I went into college knowing what I wanted to do. Now, I loved adults. I thought I was going to be at a big trauma center doing like head injury, cognitive swallowing stuff. And I didn't. I ended up doing my CF in the schools, and, you know, kudos to the school therapists. They are amazing and work with a lot or minimal resources. So it was very eye-opening and seeing that academic side, but I knew I wanted the medical side. And so there was an intensive feeding program where I was, and I interviewed, and they were like, we'll train you. And so I really enjoyed working with kids and feeding. So I call feeding, like, that was my gateway drug into like the whole airway myofunctional stuff. And, you know, the case that got me into tongue tie, and again, this was 16 years ago, so a long time ago. There weren't all the resources we have now. There weren't podcasts. There were blogs. So anyhow, there was a baby. Basically, the therapist that I was on a team with, you know, just couldn't figure it out. This baby was having difficulty breast and bottle feeding, and she was about to go on a feeding tube. And so I didn't have experience with babies, and I asked these therapists, hey, can I observe? And, you know, in my head, I'm like, hey, at some point, like, you got to retire and pass the baton to the younger therapists to see these babies. So anyway, I was like, I'll sit in the corner. I'll be quiet. And so this was my first baby evaluation I ever saw. And I think a lot of the time, like, what would have happened if I didn't go into that, right? So anyway, see the symptoms and signs going on, the clicking, mom having mastitis, all of that stuff. And they're, you know, just trying all these compensatory things and nothing's working. And so I literally Googled, Nicole, I Googled. We did not.
You Googled.
Yes.
I know 2016.
I said, you know, I typed in like poor weight gain, mastitis, lots of reflux, whatever. And I'm scouring through these Google research, and this mom blog came up, and it was called The Mommy Hippopotamus Guide to Diagnosing Tongue Ties. So super scientific, but you know what they say is like moms do better research than the FBI when their child is involved. And so I read it, and then I went and looked for professional resources on it. And you have to remember back then, like, they didn't teach these in school. They still don't. We didn't have many resources. Like Bobby Gahary wasn't on the scene. Richard Baxter wasn't on the scene. Sarush Zagi wasn't on the scene. These people were still in school. And so I didn't have a lot to go on there. And so I did get a book by Kathy Watson Jenna, and I said, hey, to my supervisor, you know, this theory fits. Can I bring this family back in and do this assessment on this baby? And basically what it was showing in the book and how it was described was what I was seeing, like right in front of me. And so in working with that baby, and she had a happily ever after story. She did not go on a feeding tube. You know, we got her tongue released. We did all the therapy and whatnot. She ended up breastfeeding. But it made me start thinking and looking at my other patients. And so it just kind of blew up from there. And one of the things that I really like is mechanics, putting all the pieces together. Okay, for chewing, what do the lips have to do? What does the tongue have to do? What does that coordination look like? What does that movement look like? How do you bring those together? And so I pretty much like anything with mechanics and, you know, using the muscles in synchrony to accomplish different health goals. So that was in infant and, you know, pediatric feeding. Well, then there was this gap of like, okay, well, you know, as a speech pathologist, we're trained to look at feeding, swallowing, communication, speech. We're not trained to look at sleep apnea or really TMJ or things like that. Orthodontic relapse, we're not really trained on that. And so I started realizing how much more this can affect. And I found the IAOM. And I remember I put a proposal in. This was my first year out when I had that patient. In 2011, I put a proposal into the hospital I was working for, and they said no, they wouldn't pay for the training. So I finally did the training later on my own, but really there was a gap with, adults. And these patients, I was seeing these younger kids, and talking to the parents about it. They're like, oh my gosh, I snore, or man, I grind my teeth, or I had braces 7 times and they went back. And so really there was that gap. And so I started zooming out the lens and seeing how oral function is a very specialized area, but when you zoom out, it has far-reaching effects. And so that's kind of how I went down the certified orofacial myology. And then I added on the IBCLC, so lactation consulting. So my goal, and I met it, was to be the first one in the world to have those 3.
Oh my goodness.
And
how did I not say that in the bio? You're the first one in the world to have no, that is amazing. And I have some colleagues who are in the process of getting their IBCLC. They just took the exam. It's a big process. It's a very rigorous exam and coursework, right? Many hours. What does it entail, if you remember?
And it's a totally different mindset too. So number 1, you have to have clinical hours. So it depends. There's 3 pathways. SLPs, we are a recognized health profession. And so a lot of us go pathway 1. If I'm already working with infant feeding, that counts as hours, right? So you have to have 1,000 hours of like hands-on patient care related to breastfeeding. And then you have to have 95 lactation specific CE, so continuing ed courses. And then from there, you pay your money and you take the exam. And then there's a whole maintenance situation of every 5 years, you have to do all these things. But I think the hardest thing is that, as speech pathology, our patient is the baby. Well, when you're operating as a lactation consultant, you have 2 patients. You have the mom and the baby.
Okay. And good point. I didn't ever think of it that way, but
okay. Yeah. I really went down the road like I knew all the baby things from courses and just experience and whatnot, but I didn't know the mom things. And so that's kind of why I went down the road of lactation consulting, because it is that, dyad going on. So anyway, I call it the oral function trifecta. And so I see babies on up, and it's really fun. People ask, don't you get tired of doing the same stuff? I'm like, no, because every mouth is different. Every situation is different. There's always going to be a case that like challenges me,
Wow. Yeah. And working with infants, it's such a crucial time period. Like you talked about, that first baby you saw, that was determining whether that infant was going on a feeding tube or not. That's very drastic. That's sort of a life-saving measure, right? And for the parent, the stress that entails, and for the doctor, for the baby, it's a very big deal. And the fact that your role and your thinking to question why and looking deeper, doing your own Google research, now it would be ChatGPT, and ChatGPT would just do it all for you. But doing your own Google research, looking that up, looking into that, changed the life for that family. And I'm so curious, what does the infant TOTs evaluation look like, or just in general, or maybe what you did in that case, and even how it's changed now, given the more knowledge that you and the general public has in tethered oral tissues?
Yeah, in general, like really just looking at feeding, and TOTs is a piece of that evaluation. So, and you're going to evaluate and look at differential diagnosis, like what factors, right? And there may be maternal factors, there may be medical factors, whatnot. So really it's case history, getting all the details of their pregnancy, their birth, how they're doing now, what their current issues are, general observations of what is this baby doing in their car seat? Is their head tilted? Do they have their mouth open? What kind of pacifier do they use, if they use one? So signs and symptoms going on. and then observations. So if you're evaluating for a breastfeeding problem or a bottle feeding problem, watch your feeding. And so that's important. And then I will use a validated measure. So the ATLIF or the Hazelbaker, that basically has numbers. You describe what the tongue looks like, you describe how the tongue moves and how it feels, and you get an actual score. I think there's so much out there of, oh, it looks really bad, it looks really tight, and that doesn't give great credibility. And then other professionals think like, oh, this isn't really a thing, or just based on visibility only. So that's kind of how it looks. And then as far as the evaluation and looking at different factors and positioning for latch and bottle type and all of those things. So from whatever we find, that's how we figure out how to move forward and address it.
Okay. And in the evaluation process, like you said, it might look a certain way, but what else is important? So you're palpating the tissue. And I know many people say the positioning in the evaluation is of utmost importance. I believe Dr. Kotlow has said that there's a higher percentage of tongue ties, he believes, than what's initially reported due to poor positioning of the infant during the evaluation. So can you talk a little bit about that?
Yeah, absolutely. Absolutely. You have to be in that inverted position. So to really see what you're looking at, you have to be at the baby's head and come over top. Because if you're going straight on and trying to lift, you can only lift so far, right? And you can't get full visualization. So that inverted position is definitely key. Also, finger position is, if you're up towards the tip of the tongue, you're not going to see a restriction that is further back, right? And so that's a big piece of it. Other things we're looking for, having the baby suck on your finger, seeing if you feel that tongue cupping or that roll or peristalsis. Tongue elevation, when they're crying, how does their tongue elevate, or is it just the sides, or does their tongue just sit there? And so you kind of get these markers and they add up, and then there's passing or not passing scores there. So it's really nice for tracking over time too. And just to have a little more, it checks me, right? Like that gives me a check and balance of, I can't just say, oh, it looks like a tongue tie, right? You need that function there.
Okay. That thorough evaluation, you're getting scores, you're evaluating correct positioning with the infant's head sort of inverted, like you said, where you're behind the head, and you're evaluating movements, functioning, palpating, mobility. The tongue bowl, I want to ask you about when the infant's crying. So I have these great pictures of both my kids right after they're born, just crying, right, coming out of the womb with this bowl, cup shape, like mid-tongue down, right?
Yeah.
And I remember showing, I didn't know at the time, but I remember showing someone that picture, and they said, well, you can't really use that as diagnostic evidence because it could just be muscle tension. So can you talk about what that means when the baby's crying and you do see a bowl shape or the mid portion of the tongue is down? What might that be signifying? And how is that different from maybe it's just tension?
Good question. So what should happen? And I always operate from the what is normal or supposed to be happening and then optimal, right? What should happen is baby's crying, the tongue flies up. And so
the whole tongue. So like the tip of the tongue?
Right.
Yep. Oh my goodness.
The tip to the middle. Yep, for sure. That is what is typical and what naturally should be happening. Now, sometimes, coming out with birth, they may have been malpositioned in the womb. They may have gotten stuck. Just birth as itself is like a huge event, and, they're getting used to breathing and gravity and, all of that. So there could be just some whole like craniofacial tension going on, and asymmetries for sure. That's a possibility. Tongue tie is also one. If it's pulling down that middle, the edges are going to be lifting, because neurologically that's what happens, but it's being tied from the middle. Additionally, it could be just dysfunction, right? So not every dysfunction is structural, but it's certainly, people want all these signs and symptoms, and certain signs and symptoms don't equate to a tongue tie. It's like a piece of the puzzle. It's a drop in the bucket. When you start adding up things, and then you have observations and scores and their history and all of that, that's when you come to that conclusion.
Okay, I want to show you the photo. Let's see if I can find it really fast, because I'm like, oh, this looks very significant. And I always go back and look at this of what, when an infant is crying, what that cupping might look like that could be significant. Okay, so let me share my screen. Here, do you see this upper right corner? That's my eyeball, because I'm like, I just had a cesarean section. Please, someone just get me out of here, because I was freaking out. But this is my son.
Yeah.
Right when he was born crying. Do you see that cupping position?
Yep. So that deep bowl.
Uh-huh.
The sides are like flying away, trying to go up like they're supposed to, but man, that middle is pulled down. It likely more of like a posterior or mid-blade type restriction going on.
Yep.
Yeah. But
isn't that a pretty great picture? Yeah. So funny, because at the time, like, I didn't even know, because this is 14 years ago. So I didn't know why we were having such bad nursing issues, although I nursed him for 18 months, because we all compensate, right?
Power through. Yeah.
Power through. Oh, just get him on PPI reflux medication and he'll stop projectile vomiting with pain and like all these things, right? Treating all the symptoms. But then when I started getting into this field of myofunctional therapy and airway, and then you start looking back on all your baby photos of your kids and you're like, oh my gosh, it's so obvious. I always look back on that one. I put that in presentations, because my son definitely had a posterior tongue tie or a mid-tongue restriction. Sort of certain angles of evaluating is that Eiffel Tower appearance, and the tip of the tongue was fine mobility, but that mid portion. So can you talk about what that posterior, quote unquote, or mid-tongue restriction, what issues that might cause?
Yeah. So when you're talking about, you're referencing from the tip to the farther back in the mouth. And so kind of in that mid-range on the body of the tongue. So, right in here, not up here, so right in that middle part. Usually that relates to the back of the tongue, the middle and the back of the tongue. So for breastfeeding, the back of the tongue is kind of the powerhouse. So the back of the tongue lifts and drops, and that's what pulls the tissue in and creates the suction to express milk. If that tongue is not lifting and dropping, we're not getting that negative pressure. And so then they'll kind of resort to many times like chomping just to compress, release. And that doesn't feel very good. That's the biggest way as far as infants go. Older kids in speech, that pesky R, getting the back and sides of the tongue up on those inner molars. I would say sleep apnea, when the tongue is resting down, the back of the tongue is like the key there. Resting down, it's in the airway, and we can't get our tongue up and out of the airway. Also, if it's restricted, you can't build those muscles because you don't have access to them. And so when you're talking about like sleep apnea and airway responsivity, moving that tongue out of the way, activating those muscles to keep the airway open, you don't have that when the back of the tongue is restricted. It can affect oral rest posture and getting that nice wide palate and maintaining it. Many times you'll see the front of the palate might be okay, but then the back is really narrow. And that's usually related to that back of the tongue not being able to be up. TMJ, same thing as airway, because they're probably grinding all night. But also when the back of the tongue isn't sealed up to the roof of the mouth and creating like this stability piece, that's when we're kind of putting our teeth together, trying to seek stability. Of course, so many implications.
But that little anomaly and so many potential implications. And for my son, his teeth had compensated really nicely, but the very mid portion of the palate almost looked like a thumbprint. Like it was, and he didn't stick his thumb or anything, but really narrow just at the mid, just at the center part. Mm-hmm. It was very narrow, and picky eating, hyperactive gag reflex. And in infancy, some of the challenges we faced, And then I'd love to hear more about the details of exactly what's going on with the tongue a little bit more when the infant's nursing. But what we faced was milk coming out of the nose. So I'm linking this to back of the tongue, maybe not elevating well to close off the airway, right? Swallowing air. So significant Orofacial induced reflux. So hugely distended stomach, projectile vomiting, like waterfall vomiting, horrible. Very colicky baby. I mean, miserable. They gave us colic drops and gas pill, all this stuff, which is just treating symptoms, of course, and the reflux medication. Basically, after nursing in the evening, we thought it was the witching hour, right? Because there's a name for everything without explaining why. I didn't know the witching hour could last 6 hours every night of a screaming, crying baby. Okay, arching his back, arching after nursing, which I assume is due to pain and swallowing air. And then falling asleep often when nursing. So the pediatrician said, put ice cold washcloths on his back when he's nursing to wake him up. I literally did that. It's almost like you want to cry when you're nursing your baby and you put an ice cold washcloth. Like, I wouldn't want that on me, except right now when it's really hot and humid where I am. But who would want that? And then your little infant, you're doing that. And then difficulty gaining weight in the first week. So what I was told was to set an alarm every 45 minutes. I downloaded an app and nursed him every 45 minutes because the pediatrician said if he doesn't gain enough weight, you have to go back in the hospital. So you have 1 week. I was like, alarm, nurse, alarm, nurse. Like that was horrible. And clicking, definitely clicking sounds when nursing. A lot of choking. There was one time when also nose was very congested. I'm assuming from the reflux, right? So I had to use the nose Frida before I nursed him every time. So saline, suck out the nose, and then nurse. And then once I remember in the middle of the night, I was nursing him and he choked because that would happen a lot. And he just went limp and turned blue. And they called in an ALTI, an advanced life-threatening event or whatever. And I flipped him over, hit him on the back, and then he came back. And it was a struggle and a challenge, but we made it through. And then I'm sure the nursing the tongue, the body compensates to produce more of a thrusting motion. And also I had issues with pain, mastitis, things like that. But the realization is none of this was ever determined. And we had lactation consultants. I was told, I think by family members, that he's probably allergic to what I'm eating. So no cheese, no dairy, no chocolate. I mean, you can't tell me no chocolate. Like, that's horrible, right? But these are all the things when we have uneducated eyes on this. And then this appears later as enlarged tonsils, sleep apnea, and all this array of symptoms. So can you help educate me and the listeners a little bit more on the mechanics of what's going on when the infant nurses? I know you said the back of the tongue goes up. Can you just do like lips, jaw, tongue? What's going on when that infant's nursing?
Yeah. So we've got to have a full opening. When we have like buckle ties, that makes it really hard. Like if you have tight here, it's really hard to open wide. So that's one thing. So first thing is full opening. All right. The tongue should be over the lower gum line. If it's not and the breast tissue is between the gums, it triggers this like phasic bite reflex. And so that's where, we get into nipple damage and pain and whatnot. So what should happen is the tongue should be cupping around the nipple. The back should lift and lower and then do this whole wave situation. That directs the liquid back and controls it from like going everywhere. Like you said, coming out the nose, it's likely the back of the tongue not contacting that soft palate. And so it can come up and out the nose. The reason that clicking occurs, and that was one of the big things that I Googled because I was like, oh my gosh, they're clicking at the breast. They're clicking at the bottom. What is this clicking situation? And so what happens is the tongue is trying to do its job. And then we've got this tie pulling it, right? And so it's trying to stay up and cupped on the nipple and sealed, and the tie keeps pulling it down. And so when you hear that loss of suction, that's the click. Well, when you lose that seal, that's when air comes in. And so air is coming, they're trying to eat and swallow, whatnot. And one of the things, they often just throw H2 blockers and PPIs at these parents. And one of the things I'll ask is like, you've been on this medication. Has it helped? And many times if it's air and not like actual reflux, acid, they'll say, no, we haven't really noticed a difference, but like the doctor said, so we're giving it to them. And so with that air, the digestive tract is one long tube from, your esophagus through your intestines and out, right? And so when you're taking in a bunch of air, like bloated, tension, pressure, and that has to be released one way or the other, right? And so until that air is released, and that's what the spitting up and vomiting is, usually these babies have a lot of gas, a lot of burps, a lot of hiccups. They typically hate tummy time for a variety of reasons, but that's one of them. And so a lot of things have to go right to be, successful, all while coordinating breathing while, so yeah, what you described is, that conglomeration of symptoms is like classic oral restriction profile. So yeah, you're spot on it. And I want to know, did your son, he did have a tongue tie? You figured that out later?
Yeah, so the interesting thing was definitely had a mid-tongue restriction or posterior quote unquote tongue tie. Yeah. And when he had his tonsils and adenoids out when he was 2 years, 11 months, they also did a tongue tie release and they did a Z-plasty. And I thought all was probably good. And this was a long time ago, so I didn't know. Yeah. Not too long ago, do I see certain like orthodontic photos are taking, I was like, oh my God, there's still an Eiffel Tower presentation when you evaluate appropriately. So we tried to do a release again, but he's having a difficult time with things. So would have to kind of be put to sleep and this whole thing. I'm like, I can't deal with that right now. But yeah, definitely that mid-tongue restriction. And I want to share something else because we are talking all about these things, and I have a slide to share also that I want to show you. This, when I look back on photos, can you see how distended his stomach was?
Yeah.
I thought this was just cute baby photos.
Cute and then baby fat,
yeah. I was just, and I didn't even like think of that as I was taking the pictures. I was like, look how cute. And then when you look back on photos, his stomach is bloated with air, right?
Poor little guy.
I know, it's upsetting. So the PPI, the reflux medication, actually helped. But he could have still been vomiting, spitting up. It just wasn't burning as much.
Well, so then he probably had both. He probably had actual acid reflux, right? Mm-hmm. And the Orofacial side of things.
And so spitting up the stomach acid and also filling with too much air, kind of like a combination. Yeah. And it's I feel like now I'm venting. I'm like, let me vent to Autumn all about my son and his issues. But I think it's educational for parents to see that these things can easily get missed. Children can persist. They're going to make it through, and there's compensations that will likely occur, and this could show up as other things, potentially worse things, if we let these issues persist. But the PPI medication tastes really bad, okay? It's like a liquid in a syringe, which is kind of hard to give your infant a syringe squirt, right? When you're like, I'm going to choke them. But it tastes really bad. So you have to go, or at least where I was, we had to go to a compounding pharmacy at Rady Children's to make it, but it only lasts a week. When you have a miserable, crying baby and you have to drive to go pick up medication and try to find parking and walk with this
week,
every week, it was a little traumatizing, like really upsetting and challenging and difficult. So I wish at that time we knew really what was going on, and we probably could have resolved these issues. But that's life, and that just helps me identify and help educate people better. So the jaw, when the baby's nursing, what is the jaw supposed to do?
The jaw is like an anchor. It does have like a little gliding motion, but what I see when I see dysfunction is like cha-dum, cha-dum, cha-dum. So it's going up and releasing, when it really should just kind of be there along for the ride and supporting. So that's that compression-based feeding. If they're not getting that negative pressure and suction, they're going to create it by clamping, releasing.
Okay, and that negative pressure then is more created from the tongue moving that peristaltic motion of elevation and depression at the mid and posterior portions. Okay, wow. So it's so precise. Like when there's something that's wrong, whether it's the swelling air or clicking sounds or whatever, that whole cascade, that whole series needs to be working correctly. And when there's a tethered tissue, whether it's lip, buccal, tongue, what kind of compensations does the baby have? You just talked about jaw clamping. What else might occur with the tongue to compensate so the baby can nurse or drink from the bottle?
Sometimes this push forward, we call it a piston, and that also kind of creates this compress, release. Tongue-wise, I mean, some of it's not necessarily compensations. Some of it's just that they can't do certain things. So if they can't get their tongue over that lower gum ridge, that's with the, phasic bite. We mentioned the clicking, peristalsis elevation. When the tongue is not doing its job, that's when we see other members of the orofacial complex come in. So that's when lips are curling in and clamping, cheeks are dimpling in, that jaw is going. So if they can't get negative pressure from their tongue, they're going to get it another way. And so, a lot of people talk about a lip tie, and if their lip doesn't flange out, it could be a lip tie, but it also could be a compensation for the tongue not doing its job. Okay. And so if they're not stable and their tongue isn't sealed on the nipple, then, they really have no choice but to stabilize and hang on with their lips, right? So there's that whole differential diagnosis there too. And you'll see those little lip callus blisters going on from that friction. Cheek dimpling, so essentially like the fish face. And cheeks should be more neutral. They shouldn't be suctioned in. What they're doing when they suction in is they're making a smaller space. And that helps to create negative pressure. It doesn't take as much to build up in a smaller space. So they are smart. They figure out a way, man.
Yeah, got to survive. So how do you determine whether breastfeeding challenges are truly related to TOTs or maybe some other underlying issue?
Yeah, I think really pulling it all together, looking at the function and the anatomy and zooming out and looking at the whole picture. Is there a milk supply issue? Is there a body tension issue and they're having trouble feeding in a certain way or certain position because, they've got some torticollis going on? Or is it a maternal issue as far as structure of the breast and the nipple or milk supply? Sometimes it's a high supply and that can cause issues. And sometimes it's a lower supply that can cause issues. Low muscle tone, like, in our special needs populations. So many different things that can be going on. And that's why you don't do a TOTS assessment. You do a feeding assessment and integrate that TOTS piece into it, because otherwise, like, everything's due to TOTS. And I do feel like that, like no one knew really about TOTS. And now they all do.
The hammer and the nail, right?
Right, exactly. And so I see that all the time. I'm going to do a TOTS assessment or I'm going to do tongue tie therapy. I'm like, there really isn't such thing. Like, you just do feeding therapy or myotherapy or whatnot.
That's a really good point, Autumn. It's not a TOTS assessment. It's a feeding assessment, because then you're taking into account all other potential contributing factors. TOTS assessment means you are kind of narrow-minded.
You're only looking for that.
Yeah. So who's ever doing the evaluation needs to have a well-rounded breadth of training and knowledge to look beyond just, is there tethered oral tissues, but what else could be going on? And probably many times it's more than just, if there's TOTs, there's probably more than one factor anyways.
Yes.
I know Dr. Harry did a study that showed like 1 out of 256 infants, I believe, who had a lip tie did not have a tongue tie. Let me say it another way. Nearly all infants, or people, but he evaluated infants that have lip tie also have tongue tie. So rarely does a lip tie exist in isolation from a tongue tie. Do you notice that or see that as well?
I absolutely do. I mean, I try to stay away from always and never, but I have truly not seen a lip tie. So it has to be restricting range of motion and causing functional issues. Okay. Not just, oh, it's there and it's low attaching. Oh, it's there and it's a little tight. Actually causing issues, right? I have truly never seen an actual lip tie that didn't have an accompanying tongue tie, but the reverse true all the time.
Okay.
Yeah. It happens often.
Yeah. And I see that. And I see in my older children, so age like 4 and above, so my beyond the early intervention age, but those, childhood through adulthood who do have a significant lip tie, nearly always have that tongue tie. And if it's not easily visible, it's because it's more posterior or mid tongue restriction. So sometimes I tell people when you're evaluating, you see there's a true lip tie, but you don't see a tongue tie, or that child went to their dentist or whoever, ENT, and they released a lip tie, but there's no tongue tie. They probably were not evaluating thoroughly enough the tongue tie, looking at the mid tongue restriction
Right.
and potential for the mouth compensations or whatever else, because it's rare to have a tongue tie and not a lip tie.
Yes.
Okay. So across the lifespan, how differently do you evaluate tongue tie in the infant population versus children and adults?
Yeah, I think, in infants, a lot of it is parent report. A lot of it is more reflexive. You're utilizing their reflexes to see how their tongue moves. Whereas when older children, adults, it's volitional, right? They have to choose to do this movement. And so it is different in that way. And also with the little ones and kids, sometimes you have to make it real exciting to get them to participate, however that may be. So I would say those are differences. You can also do more like physical measurements. So like the tongue range of motion ratio, we also have a little more clues. We have dentition that we can look at, right? We have speech that we can listen to and observe. They're not just drinking liquid. They're actually manipulating a bolus and chewing and swallowing. So there's more we can look at that point. And, I guess it's a little more glaring then because we've had years of compensations and other potential factors jumping into that. So I would say those are kind of the main differences.
Okay.
Yeah.
Well, for the infant population, what are the typical things you might think of before a release? Are there certain levels of training or hands-on manual work you do with that infant and you require that before a release? And then also after certain stretches or
Good question. All right. So I kind of coined a term. It's called therapeutic readiness. And other people out there were like, is someone ready for a release? Are they ready? And then no one could articulate what does ready mean. And so that was so annoying to me. And so it took me a while to wrap my head around it because some of what I do is just like it comes naturally to me. It's just very intuitive and I don't even realize some of the things I'm doing, And so I kind of looked at my cases and I came up with 14 factors that when I have the most optimal outcomes, these factors and benchmarks were reached before procedure. Now, there's no way they're going to be completely healed and optimal before procedure, right? Because you can only go so far. And they wouldn't need a procedure if you got everything, right? And so that therapeutic readiness, that is something that I train on and that we look at. Just to give like a couple of examples. So I have a whole handout for our courses and I have 4 categories. So universal, that's everybody that's going to have a release. These are factors for them. And then we have infants, those factors. We have toddlers and preschoolers, and then we have older children, teens and adults. So different expectations for each developmental age. But like for an infant, one of the therapeutic readiness markers is regular voiding. So like they're not completely failing to thrive. Even if they're having poor weight gain and it's related to the tie, we need a way to get them fed because we don't want to put them through a procedure and then like be in crisis, right? So whether that's a bottle or syringe or cup or something, let's get them, at least growing. So that's an example. For toddlers and preschools, general oral awareness. Where's the roof of my mouth? Where's my front teeth, right? Where are my lips? And then older children, adults, one example is jaw stability because the jaw is that foundation of accurate and precise tongue movement. So those are just a few examples of some of those 14 factors. And The reason I know, like I tell people, like, used to, oh, there's a tongue tie, not a lot I can do. Go get that tongue tie released. I'll see you on the backside, right? And that's still out there a lot. And the reason I say this now is because I've tried it both ways, right? I've been the person that's like, oh, nothing I can do. Go get the release. I'll see you later. And then at this point, I think there's way less unnecessary procedures if you get them really nice and prepared and you do everything you can do on the front end. We're going to have better healing. We're going to have faster learning and function. It's going to come quicker on the back end. And so that's just kind of what I was seeing in my practice. And so I put it out on paper and taught it.
Okay, so that's before release. And then what about after?
So after, there's two pieces to that. After, you are looking at preventing reattachment, right? And that's kind of been what's been talked about. But healing is more than just that acute stage and reattachment. Healing is the pliability of the tissue and, you know, looking at scarring or tight healing under the surface, not just reattachment. And so I do, it's called HOPE. And this is in my TOTs Gold Edition. So the big 10-year update. Like I said, I have things that work, but then when they're not working as well, or I see a different pattern, you can change them, right? Mm-hmm. So it's a HOPE healing optimization protocol with expertise. So it's basically for the therapist to guide that healing pattern, not just while the tissue's open or there's stitches in, but on down. So we have different activities. Some of them are manual, some of them are movement based. So that's a protocol I do. So that's one thing for after. Now I teach it before too, because I want them to be competent with it. And if a parent or patient can't do what needs to be done after the procedure, like I'll try it out before. Hey, do this for a week, see how it goes, right? Mm-hmm. If they can't do it before, they certainly can't do it after, you know? And so sometimes there's that little trial run to determine type of procedure and what's good for their lifestyle and what sort of education we need to do. So that's healing for afterward. And then there's moving on with like, hey, what were our goals in the first place? Now, where did we leave off before the procedure and how can we move forward to meet those goals? So say we reached therapeutic readiness and we couldn't go any further. They were having their tongue suctioned to their palate, but they couldn't sustain it, right? So you can do it, but it doesn't rest there, right? So we do the procedure, we do the healing piece, and we get back on that horse. We work on endurance. We work on habituation of that tongue being up there. Then we move on to our swallowing stuff. So I think a lot of people confuse that and like, oh, aftercare is just like the healing activities. No, you continue to work on functional goals, right?
Yeah. Like, well, I always say too, a tongue tie release is not a means to an end procedure. It's one step in achieving our overall goal.
Yes. Right? I call it the so that. So, you know, you're talking to your patient and you're like, oh yeah, we want to get our tongue on the roof of the mouth. And you can't have that goal and lose sight of why. We want the tongue on the roof of the mouth so that you're not waking up sleeping because we get the tongue out of your airway. So that it's for the therapist and also for the patient, because they're like, oh my God, I've been working on my tongue being up there for 3 sessions. Like, why are we doing this again? You know?
Right. So that, I like that. So that, let's finish the sentence. Yeah, because it's more rare that we get this, but we'll get a referral for somebody who really wants a tongue tie release and they want us to help them prepare. And I'm like, okay, wait a second. That's kind of backwards. It's usually oftentimes the myofunctional therapist diagnosing the restriction as part of their evaluation and diagnosing it because that restriction might be a contributing factor to meeting the overall goals of myofunctional therapy, which is like oral rest, posture, chewing and swallowing foods, liquid, saliva, and speech. So when we get that sort of backwards case where they're like, hi, I'd like to get in to help with evaluation for a tongue tie release. We're like, okay, wait, why?
What's your problem?
So now I'll be like, so that. I'm gonna bust the so that, because that's what we have to do is like, okay, wait, why do you want a tongue tie release? What's the problem? What's the goal you're trying to achieve? What is the actual problem going on? you can't do what, or,
Mhm.
so that's really important. I have a question before we finish talking about the early intervention aspect of this,
Yeah.
that birth through the 3-year-old age range, that's not considered myofunctional therapy. Can you talk about what that is? And, there's things like baby myo and why that might
Yeah.
be contradictory to the way we practice.
Yeah, and I think a lot of it is semantics, but it's also how we interact with our patients. So, older kids and adults, you can say, hey, do this or imitate this or try this or that, and they can follow and engage, right? Babies, it's very reflexive. Young kids, you really have to do a lot of hands on placement, manipulation, cueing, handling. It's a lot more oral motor based and utilizing feeding. Now, here's the problem is say they don't have any feeding or speech issues, but they're mouth breathing, but they can't sleep, but they have this high neuropalate, right? So you're not really doing feeding therapy with them because they don't have a feeding problem. And so that's where people start calling it myofunctional therapy. When you're doing therapy to, okay, get the tongue up, get their lips closed, right? And it's not truly myofunctional therapy just because of the way that you approach it. So, what I call it is I say oral motor therapy with myofunctional principles. So, you're taking the foundational principles of myofunctional therapy of why it's important, why you would want to breathe through your nose and your tongue up and don't tongue thrust and whatnot, but you're applying it in that younger population and framework. And older kids, we can say, okay, while you're reading this page in the book, let's keep your lips closed, right? Whereas a little kid, no, that's not going to work. You might say, okay, we're going to hum Twinkle, Twinkle, Little Star, right? They're breathing through their nose while they're humming. So it's just very different as far as the engagement of it. And we're trying to get to the same goals, right? It's just how you do it. And I think, yeah, a lot of providers are very confused on that. And general public, I try to correct that and try to correct the providers and explain that. But also, like to the public and to people that are not speech pathologists, it's just hard to delineate that and be clear about that. And they're going to call it what they want to call it. Right.
Yeah. So let's keep clarifying, because I want to talk a little bit more. So in that younger population, it's
Mhm.
different techniques. So we can have the same goals of getting lips
Yeah.
closed, tongue up, but the therapeutic techniques are not myofunctional techniques. And tell me if I'm explaining this in a way that might be different than how you would explain it. But myofunctional therapy oftentimes is more of a program that requires the child or adult to be aware of what they're doing, know the goals, be able to
Right.
look and imitate. But in that younger population, there's a lot more reflexive type skills we're working on. There's
Mhm.
a lot of hands-on manual work with certain tools that are more
Yeah.
maybe sensory based or tactile based. And
Yes.
what if a person, like you said, doesn't have feeding challenges,
Mhm.
but they do have the oral motor or the low tongue posture, mouth breathing? So is that possible to have no feeding challenges at that young age, but to have myofunctional disorder?
Yeah. And that's where I call it, are you functioning or are you functional? So in speech pathology, they would say, oh, the kid's not choking. They eat a good variety of foods. They're growing. They're functional. But if they're messy and their food is falling out, if they're super picky about what they eat and whatnot, they are functioning, but that's not functional. A parent can't take them to different restaurants and they can find something to eat. It's a social problem too. And so I think it depends on how you define, a feeding problem. I think it's very easy to be like, oh, they're choking and gagging and they're aspirating, right? That's clearly dysfunction. But what we also look at is, okay, they're not aspirating, but their tongue is thrusting forward when they swallow, right? It's the mechanics or the correctness of it. Their body is getting the job done, but it's not in the right manner.
And
And
how
so,
might the treatment of that younger child, that birth through 3-year-old age range, appear a little bit different. Can you give some examples of why that might be a different technique or approach? What might be done differently in the therapeutic process?
So I would say, it's just broken down smaller.
Okay.
And it takes a lot more reps and practice to build those skills. So an older child, like a 7-year-old, you can say, okay, put the food in the middle, move it over to the side, right? And they can usually go along with that and follow that, or at least attempt it. Whereas with a little one, you may have to do some training of, okay, where's the front of your mouth? Okay, where's your big teeth? Where's your front teeth? Right? Teaching them having that awareness. You also may place it over on the side for them. You also may use a chewy tube or something to build up that side jaw strength and awareness of where the food should go. So it's just more involved, I guess.
Yep.
Lots more patience.
And would you say you need a specialty training to be able to work with that early intervention population?
I definitely do. Our field is so big as speech pathologists, but I feel like it's definitely a specialty area. And I just want to say it's okay if someone doesn't want to do that. You don't have to do everything. I don't do stuttering. I think being a specialist is really important because you can dedicate and be like the best you can be at that area. Whereas just having that huge general scope is overwhelming. And I do think, yes, you not only do you need to have training and to specialize, you have to have the heart and the want. I found that therapists are not good therapists if it's a area that they don't want to do. And if you don't enjoy it, you're not going to be great at it.
You're getting frustrated because I know with those younger age groups, there's a lot of sensory pieces that you have to tackle, and you don't go right in the mouth. You might start with massaging the arms, the shoulders. So, obviously it's in the scope of an SLP's practice to be able to work with feeding and work with that young age group. And then you choose, do I want to train and specifically work with that or not? What about other practitioners who maybe take myofunctional therapy courses? Should they be working with young children under the age of 4, or should those specific programs that should be reserved for those older 4 and up, and maybe referring out to the specialists for the younger age groups?
Yeah, I definitely think just because it is different. If you take a myofunctional therapy course, they're not going to teach you about babies suck, swallow, breathe, right? They're not going to teach you about typical speech development. They're not going to teach you about feeding development either, right? It's truly, okay, here's the goals of myofunctional therapy. Here's why you would want to tackle those goals. Here's some ways that you can use exercises to meet those goals. And so, yeah, especially, I find that the therapy profession is very different than the outside of therapy profession, just because they don't have that developmental background. Now, if other professions want to go and take that coursework or get their degree in that or some sort of certification or whatnot, then yeah, go for it. And then that will equip you. And that would be responsible practice. The thing of just going and doing it and trying to apply something that's for older children and adults to little ones, that's kind of irresponsible in my opinion, because you can hurt people. Are you going to kill anybody with myofunctional therapy? Probably not. But with the little ones and babies, you certainly can cause harm. And what pieces are you missing, right?
Yeah, I think that's important.
Yeah, if you only know about, breathing through your nose and your tongue needs to be up and whatever, or a child is, 6 months old and you're like, oh my gosh, that tongue thrust has got to go, right? Like that's developmentally appropriate there. And so, yeah.
And a lot of the oral sensory motor aspect is not myofunctional therapy. So when I've taken courses with Diane Barr and different courses like that, there's a lot of tools that are used in an oral sensory motor approach that have nothing to do with myofunctional therapy, Ziva, all these just different things that you might use and know about to trigger reflexes and specific movement patterns and skills. It is very different.
Yeah.
And you said about breaking down tasks with the younger ones, you're breaking it down into specific skills and step-by-step parts to achieve each goal. And I guess if you're not thinking about those smaller aspects, there could be gaps in what you're trying to teach. If you just go for the big picture of we want tongue up, lips closed, nose breathing, you need to be aware of those underlying foundational pieces. So I see, like I've lectured for orthodontic groups and they say, well, if we get a young kid, maybe age 3, we see dysfunction, but there's nothing we can do. And I'm telling them, no, refer to a speech pathologist that has training in the oral sensory motor with that early intervention age group. They can start doing wondrous things for these younger children. So sometimes I see on Facebook groups or certain social media where parents may post about their young child. My 3-year-old did myofunctional therapy. It didn't work. So I guess it's also important for parents to realize some of it's semantics. What is myofunctional therapy? Who did you work with? But it's not really myofunctional therapy when they're in that under 4 age group, right? It's kind of, and it's hard and confusing to differentiate, but I think you did a really great job helping to separate that out, what that is.
Good, I tried.
The differences. Yeah, I think it's confusing because we see dysfunction in those younger children and they can have myofunctional disorders. We can see myofunctional problems, but the way we approach it and treat it is typically going to be different when they're really young. And in our office, we actually have a speech pathologist in a different location, different business that we refer to when we get the really young ones, because that's what she loves and that's her specialty. We might work with the delayed language kids and on the floor working on babbling and stuff, but more of the feeding oral sensory motor, they go to her. She's not my practice. She's a totally different business, but that's not our passion because we're just not trained adequately for that. And we know that. And then she refers the older kids to us and the adults. So it works. Pick what you like and what you're trained in and what you're really good at. Yeah, this is great. So let's think of a couple final things before we end in the next minute or two. What's one tongue tie myth you'd maybe like to retire forever? What's one myth about tongue tie that you're thinking, not good? Let's get rid of that line of thinking.
There's so many.
Okay.
There's
like,
so
too
many.
Much pressure. Okay.
Oh gosh.
Bust out a few. Just tell me a few.
One thing is like people just say there's a tongue tie to make money. Therapists and dentists, they're just enjoying, saying that kids and people have tongue ties so that they can make money. And here's the truth of that. I would have so much more cash flow if I just pretended there's no tongue tie, right? Because they'd be coming to therapy for years. And that's what we see, right? We see the kids that have been in therapy literally till middle school. And then they finally make their way to us to address an underlying issue. Or, what else? That's a big one. And honestly, you know this, in dentistry, people can do way more financially lucrative procedures and stuff than tongue tie releases, So
and I know that's why a lot of people don't utilize insurance for tongue tie releases. A lot of practitioners, dentists, or who's ever doing the release, because it's not even, they don't even make any money. They probably lose money going through insurance because of the equipment they need and the time and everything. So it's not a lucrative business. It's more, you see there's a problem and you need to help.
Right. Exactly. It's a passion for a lot of people. That's one. Another one is, same day tongue tie centers. Not really a myth, but a thing out there that I want to get rid of. You come in, you get your evaluation, you get some body work, and you do your tongue tie release that day. Like, that is not enough time. You've already scheduled a tongue tie release, but you haven't been evaluated. What? And it's just kind of like a one size fits all. Oh, everyone gets a tongue tie release. Everyone gets body work. And you haven't built that relationship. Today's the first day you're meeting them, right? And sometimes you don't know right off the bat, right? Sometimes it can be a little more of a over the longer period of seeing what they can do therapeutically and then continuing to assess. So I would like to get rid of those.
Yeah, no, I think that's great. And I think it's also important to note that just because the tissue may appear restricted, it might not be functioning, or the person might not be functioning in a restricted way. And it takes that therapy to see if a release is even really needed.
Right.
The person can learn muscle strength, range of motion, and you might think it appears restricted, but it might not actually require a release. It takes that good, keen eye, that experienced clinician. And I really, Autumn, thank you so much for joining me today. This has been really awesome. Great conversation. Of course, I love talking all about tethered oral tissues and learning more about the infant population and that early intervention age group. And I really appreciate all of your time and your knowledge in evidence-based care, but also clinical cases and what you're learning from the patients you see starting on that very first almost feeding tube patient. I mean, what a great insight you had. And I think it's really meaningful that you started getting interested in this aspect of the field by questioning the why. What's going on? What's causing the issue, not just treating symptoms. And that led you to be an expert clinician and instructor. So it's so wonderful that you teach a bunch of courses. Could you talk about some of your courses, when they are, what they are about, so people can sign up?
Yeah, so we really have two formats. We have live online, which everyone's online at one time, and we go through the course together. I am not a sit and lecture course person. You get a supply list and we do exercises together and different learning activities and things like that. But our main course, our TOTs training, it's in the gold edition now. So fully updated, lots of new goodies. We give you a ton of resources, handouts, videos that you can look back on. And so that's TOTs Gold. That goes over our E3 model of care. So not just a course about tongue ties, it's actually a whole model of care and how to put all the pieces together and treat them. So that's TOTs Gold. Then on demand, we have Plot the Tot, which is basically people that say, I want to see a case from start to finish. Mm-hmm. So we have 3 cases, an infant, a kid, and an adult. You see everything from start to finish, from full evaluation to our therapy, to the release and the actual surgery, to what happens after. So that's that start to finish. And then we talked about the therapeutic readiness. That's online, on demand. And then our advanced myofunctional therapy course called the Stones approach. We go into a lot of extra stuff that intro courses don't. Okay, you know they need expansion, you know they need tonsils out, you know they need whatever, and a tongue tie release. Which happens first? Which happens second? How do you decide? What's the timing of that? TMJ is like a wild animal. Very few people understand it, and it's so multifactorial. So we do a lot on TMJ, a lot on sleep, specific TMJ interventions and sleep interventions. Yeah, so a lot of clinical decision making there. And then a couple other just short on-demand online. If you're dipping your toe in Myo, we have an intro, like very basic intro to Myo. Seriously, like 30 minutes. Just to see if it's something you're even interested in. How to become an IBCLC. So if you're looking to get certified or dual certified, goes over the ins and outs. The website is really confusing. So that's why I kind of created this one. And then confidently connecting for collaboration. So this is a course people need so bad because you can't tackle a tongue tie on your own ever. And professionals everywhere are like, oh, I can't get an ENT on board, or, oh, I can't find an orthodontist that is willing to do expansion, or whatever it is, building that team. And it doesn't come from dropping off goodies at their office. It comes from intentional relationship building. And so we have a lot of regular referral sources. And so how we cultivated that is through this relationship building. So I kind of take through of what I did, how I did it, and how I keep up those relationships.
Wow, you have a lot of courses. I did not realize how many courses you had. Wow.
Yeah.
You're a busy lady. Oh my goodness. So for these courses, what specialists are these appropriate for, and where can they get more information?
Yeah, as far as our tongue tie course, really anybody that is involved in the care of patients affected by tongue tie. And that could be an ENT, an orthodontist, any of the therapies, even like chiropractors. And my thing is, I've taken orthodontic courses. Do I do orthodontics? No, but I want to know about it so that I can talk intelligently and make referrals and really gain my own understanding. All that's required is, hey, you have to be a medical professional or dental professional and part of the team taking care of patients that may have a tongue tie. And we just say in our course, like, hey, just make sure you stay in your scope of practice and ethical guidelines. Because yeah, at this point I could do a really great frenectomy, but that's not my license.
Right.
So yeah, variety depending on the course, but in general, we'll use that. And then just finding me over on Instagram or just our website, chrysalisorofacial.com. Shoot me a message. Love to chat. If anyone has any questions, just reach out.
Perfect. I appreciate that so much. I thank you so much for all of your time, your wisdom, and all of the teaching that you do to spread this information. You could tell it's truly your passion, not just doing the work you do, but helping teach others. So thank you so much, Autumn. We really appreciate it. Have an awesome rest of your day also.
All right, you too. Thank you.
Thank you. Take care. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.